ECGs look scary at first, but they don't have to. By the end of this video, you will feel much more confident approaching ECG questions in the future. Hey everyone, my name is Mahdi, and I scored 267 on my STEP exam, and I'm a USMLE tutor with a match guy. And today, we're breaking down the ECG in the most effective way possible, directed to what actually shows up on the USMLE. But before we do that, make sure to grab our free high-yield resources for Step 1, Step 2, and Step 3. You can download them completely free using the link in the description. Now, guys, before we start talking about pathological patterns and how to approach them in the smart way, let's first look at the normal ECG. The normal ECG showing the normal electrical activity inside the heart, with the P wave showing atrial depolarization, the QRS showing ventricular depolarization, and the T wave showing ventricular repolarization. Now, each P wave is followed by a QRS complex, and this tells us that this is a sinus rhythm, a rhythm that's coming from the SA node, which is the normal rhythm inside the heart. Now, the second thing I want you guys to focus on is the PR interval, which is the distance between the P wave and the R wave, and it should normally be 0.2 seconds or one large box. And this number is super important because it's going to be affected in a number of pathologic conditions that we're going to talk about later in the video. Now, I want you to learn how to calculate the rate. The rate is calculated by dividing 300 over the number of large boxes between two R waves. So meaning, if 3 boxes, the rate will be 100 beats per minute. And if 5 boxes, the rate will be 60 beats per minute. So me personally, I just remember these two numbers. 3 boxes or less, this is tachycardia. 5 boxes or more, this is bradycardia. And that's it about the rate. Now, let's look at this ECG. And before we do that, I'd like to thank Dr. Dean and Dr. Steven for giving us the right to use these amazing ECGs. Now, guys, based on what we just talked about, I want you to try this one by yourselves. Take a look at this ECG and tell me what do you see. And of course, you can pause the video for a few seconds if you need time to think about it. But I'm answering that if you counted about 3 large boxes between 2 R waves, this means that the rate is about 100 beats per minute. And that this is sinus tachycardia. Why? Because everything else is normal. Every P wave is followed by a QRS. The rhythm is regular. The only difference here is that the heart is simply beating faster than usual. And that's the key point. Sinus tachycardia is not an abnormal rhythm. It's a normal response. You will see it in things like fever, pain, dehydration, anxiety, anemia, or hyperthyroidism. Okay? Now, let's look at this one and tell me what do you see here. For the video, if you need time to think about it, but you should easily notice that there are 6 large boxes between the QRS complexes, meaning that the rate is slow and that this is bradycardia. And again, look at the P wave. Every P wave is followed by a QRS with a regular rhythm. So this is sinus bradycardia. And again, sinus bradycardia doesn't have to mean disease. It can be completely normal in athletic people or during sleep, but in other situations like taking beta blockers or hypothyroidism or increased vagal tone, maybe also due to these situations, okay? Now that we understand how normal ECG looks, it's time to start talking about the real stuff. There are basically 2 ways to approach the ECG. The first one is the one they love to teach in medical school, which they call the systematic approach, where they tell you to first look at the rate, then the rhythm, then the axis, then the P wave, the QRS, the ST segment, and before you even finish your question, your exam timer is already halfway done. So of course, this is not practical for the USMLE. That's why I like to use what I call the instant approach. The instant approach is based on pattern recognition. You basically train your eyes to recognize the classic ECG patterns that show up again and again, and that's exactly what we're doing in this video. We will go through the most common ECG patterns and learn how to spot them instantly. Now, look at this ECG and tell me, what do you notice? Of course, go ahead and pause the video for a few seconds if you need time to, but you will notice that these are not distinct P waves. These show sawtooth-like pattern, and the rhythm is regular. So, sawtooth-like pattern and the regular rhythm, these are classic clues for atrial flutter. Now, what's basically happening here in atrial flutter, there is a re-entrance circuit spinning around the right atrium. It's usually in the tricuspid annulus, and that circuit keeps firing rapidly, creating those repetitive flutter waves that you see on ECG. You'll notice them best in the inferior leads, and we will talk later in this video about the leads, so leave it for now. But for management, the curative treatment is usually catheter ablation, and that simply means that we insert a thin wire that goes through a vein into the heart to burn and destroy the re-entry circuit, causing that flutter. Now, it's most important to differentiate this from the following ECG. Take a look at this one, pause the video if you need to, but you will see that there are no distinct P waves at all, just continuous chaotic baseline. And if you look at the RR intervals, they are completely irregular, no repeating pattern. These are classic features for atrial fibrillation. What's basically happening here that instead of one organized electrical signal, you have hundreds of random impulses firing all over the atrium. And I want to emphasize that this will lead to loss of contraction, meaning the blood can pool and form clots, especially in the left atrial appendage, putting the patient at risk for embolic strokes. Now, another important USMLE step is that in new onset atrial fibrillation, you need to always check the TSH, because hyperthyroidism is a very common reversible cause. Now, guys, if you like how I'm explaining things here, you can actually try a free one-on-one tutoring session with me or one of our top tutors. We will walk you through the concepts you're struggling with and build you a personalized study plan. The first 30 minutes are completely free. You can see if you like the tutor style or not. So check the link in the description and you can take it completely risk-free. Okay, look at this ECG and tell me what do you see here. Go ahead and pause the video for a few seconds if you need time to think about it, but you will notice that you can actually see distinct P waves before each QRS, unlike atrial fibrillation, right? But these P waves look different from each other, and the rhythm also looks irregular. So these are classic clues for what? You can pause the video if you need time to think about it, but these are key clues for multifocal atrial tachycardia, okay? Now, what's basically happening here is that instead of one pacemaker in the atria firing the impulses, you have multiple different sites all trying to take control. Each is producing its own P wave with a different shape and PR interval. So the ECG ends up showing, as we just mentioned, irregular rhythm, at least 3 different P wave morphologies, and narrow QRS complexes. Okay, and again, if you see irregular rhythm with visible but variable P waves, think of multifocal atrial tachycardia and not atrial fibrillation. Okay. The exam question will be as follows. They will describe an elderly COPD patient in mild respiratory distress with an ECG showing irregular, narrow, complex tachycardia with at least 3 different distinct P wave morphologies, and they're going to ask you what is the next step in management. The correct answer is to improve oxygenation, not antiarrhythmics or cardioversion. So the point is, once oxygen and ventilation improve, the arrhythmia often settles on its own. So again, COPD, regular narrow tachycardia, this is multifocal atrial tachycardia, okay? So look guys, if you feel overwhelmed going through all this alone, we built a 7-day USMLE crash course. It's 6 to 8 hours of live tutoring each day, covering every high-yield topic for step 1, step 2, or step 3. It's totally risk-free. If you attend the first session and you don't like it, we will give your money back, no questions asked. And the goal is to help you master everything you need for your exam just in 1 week. You can sign up using the link in the description below. Okay, now let's look at something that's more serious. Take a look at this ECG and tell me what do you see. And go ahead and pause the video if you still need more time to think about it. But I'm talking again in 1, 2, 3. So you will see the rhythm is regular, but the QRS complexes are wide. By other words, meaning 3 small squares, more than 3 small squares. And there are no clear P waves before each QRS. That tells you that the impulse is not coming from the atria, it's coming from the ventricles. That's the classic pattern for what? Pause the video if you still need more time to think about it, but this is monomorphic ventricular tachycardia. So basically, in monomorphic ventricular tachycardia, the ventricles take over as the pacemaker because of an entry circuit, probably in an old scar tissue from a previous myocardial infarction. okay? So since the same area keeps firing repeatedly, the QRS complexes all look identical. And that's why we call it monomorphic, okay? So as I told you, this is due to post-myocardial infarction, re-entry in a scar tissue, and always think of it in a patient with a history of coronary artery disease who suddenly becomes hypotensive or loses consciousness. Okay. On ECG, regular white complex tachycardia, this is monomorphic ventricular tachycardia until proven otherwise. And they will ask you, what is the next step in management? The next step is immediate synchronized cardioversion if the patient is unstable. But if the patient is stable, you can start with IV amiodarone, okay? All right, now let's look at this ECG. And I want you to tell me what's going on here. Like, look carefully at the QRS complexes. Go ahead and pause the video if you still need more time to think about it. But these are not identical like the last one. They seem to be changing in shape and twisting around the baseline, okay? So I'm answering in 1, 2, 3. So basically you can see that the QRS complexes are wide, polymorphic, and they appear to be twisting around the baseline. And that's the classic look for Torsades de Pointes, which basically means twisting of the points. And what's basically happening here in Torsades is that it's a special form of polymorphic ventricular tachycardia that occurs when the QT interval is prolonged, okay? So always look for it in someone with prolonged QT for the onset of the Torsades. Common causes include electrolyte imbalances, medications, or congenital long QT syndrome. So they will ask you something, for example, like a young woman on a macrolide antibiotic or an antipsychotic, and she's coming with the ECG showing that twisting wide complex rhythm, and they will ask you, what is the next step? The next step, guys, is to give IV magnesium sulfate, even if the magnesium is normal, okay? But of course, if she was unstable, in this case, you will defibrillate immediately. But if she was stable, you give the IV magnesium sulfate, regardless of magnesium level. All right, now look at this ECG and tell me, what do you see? Like, go ahead and pause the video for a few seconds if you need to look at it. But does this look like anything that you know? Does it look organized in any way? Like, can you identify any QRS complexes or P waves? Exactly, like this ECG is pure chaos. It's irregular, no consistent pattern, no identifiable QRS complexes at all, and that's why this is ventricular fibrillation, and this is the most serious arrhythmia there is. And what's happening here is basically that the ventricular muscle fibers are firing randomly with no coordination whatsoever. So this means that there is no organized contraction and therefore no cardiac output. So basically, ventricular fibrillation is cardiac arrest, which needs immediate defibrillation. And of course, the most common cause for this is myocardial infarction. Okay? All right. Now for the next one, I want you to look closely at the PR interval, the shape of the QRS, and tell me if you see anything unusual about the upstroke. Go ahead, pause the video for a few seconds and analyze it. But you should be able to see 3 classic findings. A short PR interval, less than 120 milliseconds, a slurred upstroke at the beginning of the QRS, that's called the delta wave, and the QRS complex itself looks a bit wider than normal. This is WPW syndrome. And what's happening here is that normally electrical impulses travel from the atria to the ventricles through the AV node, and this creates the casual PR interval that we are all familiar with. But what's happening in this condition is that there is an accessory pathway, and that pathway is called the bundle of Kent. This connects the atria and the ventricles directly so that the AV node is bypassed. And that's what we call pre-excitation. This creates the short PR interval and the delta wave that we just saw. Now, on exams, the most important thing that's asked about that is that you need to avoid drugs that block the AV node in people with this condition. Drugs like beta blocker, calcium channel blockers, adenosine, or digoxin. Okay, and the definitive treatment for this is to ablate the accessory pathway, just like we did in Atrial Flutter. You ablate the accessory pathway. Now look at this one, and tell me, what do you see? But I want you to focus on the distance between the P wave and the QRS complexes. Go ahead and pause the video for a few seconds if you need to think about it. But you will see that the PR interval is longer than normal. meaning more than 0.2 seconds, meaning more than one large box, meaning more than 5 small squares. And that's why I told you that this duration is important at the beginning of this video. And every P wave is still followed by a QRS complex. So a longer PR interval and the P wave is followed by the QRS complex. What is this? This is first degree AV block, and it's a benign condition. It doesn't need treatment, and that's the most important question that's asked about it. Does this need treatment? No, it doesn't. You just need to observe. And this is very common in athletic people, or also in people who take beta blockers or calcium channel blockers. Okay. Now let's look at the next ECG. What about this? Like focus on the PR interval again. Like tell me, does it stay the same or does it change from one beat to another? Go ahead and pause the video if you need to look at it. But you will see that the PR interval keeps getting longer until finally one P wave is dropped, or sorry, one QRS complex is dropped. And then after that, the cycle will reset and repeat. So a progressive prolongation in the PR interval followed by a dropped QRS. What is this? This is Mobitz type 1 second degree AV block. Now, guys, what's basically happening here is that the AV node gradually becomes fatigued. So each impulse takes a bit longer to get through it until finally one beat is completely dropped. And the reason for this could be increased vagal tone, or again, beta blockers, or anything that may block the AV node. And the most important thing about it is that they are going to ask you about the management. If the patient is asymptomatic, this patient requires no treatment. So again, longer drop. This is Mobitz type 1. Longer PR interval until one is dropped. Now, look at this one. What do you notice here? Again, focus on the P waves and the QRS complexes and tell me that if each P wave is followed by a QRS complex or not. Take a second for the video if you need to think about it, but you should be able to see that the PR interval is consistent, but still there is a drop in one of the QRS complexes after this. So this is what? This is no progressive prolongation, but a dropped QRS complex. What do we call this? We call this a second degree AV block, Mobitz type 2. Now, what makes it different from the last one is that in this case, the block isn't in the AV node. It's usually below the AV node in the Hesburgh-Purkinje system. And that's why it's more serious and unstable. But unlike type 1, this one is always pathologic and can progress to complete heart block. Now, regarding management, these patients need a pacemaker. Even if they are asymptomatic, they need a pacemaker. So when you see constant PR interval and sudden drop in the QRS, this is Mobitz 2. And you need to always remember these patients need pacing regardless of symptoms. So by the way, if you want all the high yield info like this covered in one place, you should check our free high yield files on step 1, step 2, and step 3. You can download them completely free from the link in the description. You will sign up and you'll start getting them delivered right to your inbox. Now, what about this ECG? What do you notice? Like, look closely at the P waves and the QRS complexes. What is the relation between them? Go ahead and pause the video for a few seconds if you need to, but you should be able to see that the P waves and the QRS complexes are merging independently from each other. Like the atria and ventricles are each doing their own thing. Like the PP intervals are regular, the RR intervals are regular, but they have no connection between each other. This is what we call a third degree AV block or a complete AV block. And they may ask you, what is the next step in management? Your next step in management is transcutaneous or transvenous pacing, But the definitive management, if they ask you what is the definitive management, it's a permanent pacemaker. Permanent pacemaker is required in these patients. Now, focus on this and this ECG, and I want you to exactly focus on the QRS complexes, on the height of the QRS complexes. What do you see here? For the video, if you need a few seconds to think about it, but you should be able to see that the QRS complexes here are much higher than usual. And sometimes also in this condition, you may find ST depression and T wave invergence, telling you that this is a left ventricular strain. So what do you think of when you see a higher QRS complexes than usual, plus ST depression and T wave inversion, implying that there is a left ventricular strain? This is a left ventricular hypertrophy. okay? And what's basically happening here is that the left ventricular muscle is thickened, usually from chronic pressure overload. And that increased muscle mass generates higher electrical voltage, which is why the QRS complexes look huge here, okay? And the most common causes for this are hypertension, aortic stenosis, and hypertrophic cardiomyopathy. Right, now let's talk about one of the most high-yield parts of an ECG, which is the ST segment. The ST segment is the flat line between the QRS and the T wave, and it represents the period between ventricular depolarization and repolarization. And the reason it's so important because its relation to the baseline tells us if there is ischemia, injury, or infarction. And the golden rule for that is whenever you see ST elevation, you think of acute injury or infarction like ST elevation, myocardial infarction, or pericarditis. While on the other hand, if you see ST depression, you should think of non-ST elevation, myocardial infarction, or unstable angina. Again, so whenever you're reading an ECG, your eyes should always check the ST segment. This diagram here I put to show the 12 leads of the ECG that shows the heart, and I like to think of them as camera angles, that each is filming a part of the heart, each is filming a wall of the heart. And basically when you see ST elevation or ST depression on these leads, you will figure out which part of the heart is affected, and based on that you can figure out which coronary artery is affected. So for example, if you see that lead 2 or lead 3 or AVF is affected, this means that the inferior wall is affected, and this is supplied by the right coronary artery. So now you know that the problem is within the right coronary artery. If you see that lead 1, AVL, or V5 or V6 is affected, this means that the lateral wall is affected, and this means that this is a problem within the left circumflex artery. If you see it in V1 to V4, this is the anterior wall, and this is supplied by the left anterior descending. And finally, between V1 and V2, this is the septal part, and this is supplied by the proximal part of the left anterior descending artery. So whenever you see ST elevation or ST depression, you can instantly know which part is affected, which leads are affected based on that, which part is affected based on that, which coronary artery is affected. Now let's test this and see what's happening here. Look at this ECG, look at the ST segment. Do you see here depression or elevation? Pause the video if you still need time to think about it, but you should see that there is ST segment depression and T wave inversions in multiple contagious leads, and this pattern means that there is subendocardial ischemia. The inner layer of the myocardium isn't getting enough blood, and this is classic appearance for non-ST elevation myocardial infarction. Now guys, based on what we just discussed, I want you to tell me which part is affected, which leads are affected, and which artery is affected. So the affected leads are lead 1, lead 2, and AVF. And those are the inferior leads, meaning that the artery that's involved is the right coronary artery, okay? Now, how to make sure that this is a non-ST elevation myocardial infarction and not just an unstable angina? The way you tell them apart is by measuring the troponins. If the troponins are elevated, meaning that this is a non-ST elevation myocardial infarction, normal troponins, this means that this is an unstable angina, right? Now let's look at the next ECG. Focus on the ST segment and tell me, is this an elevation or a depression? So you can clearly see the ST segment elevation in 2 or more contagious leads. That's the key pattern for ST elevation myocardial infarction. And what's happening here is that unlike non-ST elevation myocardial infarction, this time there is complete occlusion of the coronary artery, causing transmural full thickness injury to the heart muscle. And again, I want you to tell me which artery is affected based on the leads that you find here. And again, the affected leads here are the inferior leads, meaning that the affected artery is the right coronary artery. Now, there's an important fact, guys, I want you to know about the inferior myocardial infarction is that these patients can't take nitrates. Nitrates will worsen the condition, and they will lead to decrease in the cardiac output and will lead to hypotension. This is super high yield to know, and for those of you who want to cover all high yield material quickly and efficiently, just like this one and all other high yield information, you need to check our live 7-day USMLE bootcamp. We have one course for each USMLE step where we go over every high yield topic daily for 6 to 8 hour sessions. They are live sessions and they are also recorded. You will have access to them, and it's 100% satisfaction guaranteed. Because if you don't like the first session, you can take your money back and no questions will be asked. The link to join is down in the description. Now guys, the fact that we talked now about the ST elevation and specific lead points, let's talk about what if you see a diffused ST elevation pattern, meaning that's present in almost all leads, not just one area. Go ahead and pause the video if you still need time to think about it, but this is classic for acute pericarditis. You can see that the ST elevations are widespread, concave, giving a smiley appearance, meaning it's not that bad as ST elevation, myocardial infarction, and sometimes you also can spot PR segment depression. Okay, so these are strong clues that this is pericarditis, and what's happening here is that the entire pericardium is inflamed, so every surface of the heart gets involved, and that's why you see widespread ST elevation there, and not just localized like the one you see in non-ST elevation myocardial infarction. Now, the case will be something like this. Pain, and the pain will be sharp and pleuritic, worse when lying flat, better when leaning forward, okay? And it's also important to know that one important complication for this is that this may lead to pericardial effusion. This is basically when fluid starts collecting around the heart, and that will lead to the electrical signals getting damped. And that will show up in ECG as low voltage QRS, meaning the waveforms look smaller across all leads, okay? So if the effusion becomes large enough, it can even lead to cardiac tamponade. So always think of it. Diffuse ST elevation, this is pericarditis. Diffuse low voltage, this is pericardial effusion, okay? This concludes our video, guys. I hope you found this video helpful. And I understand that some students might still need more explanations of this topic or any other topic of their choice. I'm happy to help you one-on-one. As we offer free sessions, you literally talk to me for half an hour to see if this is helping you, or if you like it, or if you can commit to something more. And you can do that by signing to the link in the description below. It's completely free. And please feel free to leave any questions you may have in the comment section. And also, you can send them to our support team at info@thematchguide.com. And we'd also appreciate if you like the video, share it with your friends who are preparing for the USMLE. And yeah, don't forget to grab our free high-yield resources I told you about in the beginning. Make sure to also to watch Dr. Asad videos on how to prepare for step 1, step 2 in 2025 based on the step you're preparing for. And thank you guys for listening.